I would like to second Jeff in inviting you or welcoming you back after lunch on such a nice sunny Saturday afternoon. So what I'm going to share with you is very much a group effort. No disclosures or conflicts relevant to this. I did have a little bit of a conflict with my topic, contour anatomy. It's a very broad topic, and I was having a lot of trouble keeping this under 20 minutes, so I decided to narrow the focus and maybe shift a little bit. I'm going to talk about a new pattern of failure in the head and neck, and I think this is related to contour anatomy because patterns of failure analysis have been highly influential in contour anatomy and radiation oncology in the head and neck and other sites. So in spite of the high influence of patterns of failure analysis, experts exhibit large inter-observer variability in contouring sample patients. This has been shown in multiple studies for the head and neck and other sites. This particular study asked the question, does PET-CT help? So there were 8 head and neck experts, 10 sample patients. The gross tumor volume was contoured on contrast-enhanced CT, and then FDG PET-CT images. The addition of the PET-CT did not reduce variability between experts in this study. That leads us to think a little bit about plan quality. If these expert contours are variable, some of them may be better quality than others. And plan quality is really critical for our patients. The TROG 0202 trial was an international phase 3 trial looking at radiation with cisplatin with or without tirapazamine. And the authors in a separate analysis looked at plan quality. More than 25% of the patients had non-compliant plans initially, but these were evaluated in real time and changes were recommended, but still 25% of the patients had plans that were not changed. And a secondary review of this showed that about half of the non-compliant plans had deficiencies with a predicted major adverse impact on tumor control. This was more of a problem for centers enrolling few patients, 30% if you enrolled less than 5, less of a problem for centers that enrolled more than 20 patients, only 5% non-compliant rate. But the 2-year survival was significantly different for these groups, 50 for non-compliant versus 70 for compliant plans. This 20% difference is larger than the expected benefit of the intervention for the trial. So again, plan quality is critical, and it means a lot. It's important for running a cooperative group trial, but also for the individual patients that we all treat because of the big difference in survival. So in terms of patterns of failure, there have been quite a few studies looking at patterns of failure in the head and neck. I'm going to show you what an infield failure looks like. It's pretty clear. This is a patient that had an oropharynx cancer, lymph node in front of and behind the jugular. After treatment, this lymph node shrank down to normal size or less than a centimeter. This one in the back of the jugular was gone. But there was clearly persistent disease in this patient, and a salvage neck dissection was performed. But in terms of a patterns of failure analysis, this would be called a failure, and this turquoise line is the field, so it's an infield failure. It's not good that the patient failed, but infield failures are considered acceptable failures because you understand the anatomy and the natural history and the path of the cancer. So it failed because it's a bad tumor, but not because it was a bad contour. Then there are few marginal failures. In most of the studies, marginal failures are rare. This is one of our marginal failures from our early IMRT days. The red area is the high dose and blue is low. So we tried to get too fancy here and spare the parotid in a high-risk neck, and that led to a failure. Again, we learned a lot from our few marginal failures, and most of the studies are pretty consistent that marginal failure is not a big problem with IMRT. So our practice at WashU has been to fuse all images of disease recurrence with the original CT simulation images. And so that led us to realize that unrecognized disease progression on new 3D imaging incorporated into radiation oncology practice over the last 10 years, that's the new pattern of failure. And I'll show you what that looks like. So these are 5 patients that failed, and we looked at their failure on their recurrent images, and they all failed in the subclinical dose side. And I don't know how well you can see that, but 4 of these have small, less than 1 centimeter lymph nodes with central necrosis. This one didn't. So I don't think we would recognize this as a problem without looking at all of the failures. So what is the new 3D imaging and radiation? It wasn't too long ago where we did a 3D diagnostic scan, we did 2D simulation, 2D radiation therapy, and then we looked at follow-up scans at about week 16. Now we do diagnostic scans. We do a 3D CT sim, sometimes MRI sim. We do radiation therapy, and we can get a 3D image every week during treatment or even every single day, and then follow-up scans. So these images really exist within radiation oncology. Our colleagues, the surgeons, medical oncologists, and diagnostic radiologists really rarely see these images. These are certainly, of course, meant for contouring the anatomy, normal tissues, and tumor. These are meant to check alignment in 3 dimensions before treatment. They're not meant to look for tumor progression, but nevertheless, they are 3D images, and I'll show you that sometimes you can catch tumor progression here, and it makes a big difference in patient's outcome. So a few examples here. This is a patient with a left-sided oral tongue cancer and a left-sided level 1B lymph node. There's a normal-sized lymph node in the contralateral 1B, and this is the submandibular gland. So this patient had a partial glossectomy, a left neck dissection, and our goal was to treat the left neck with a adjuvant post-op dose of 60 gray, and to treat this side of the neck with a subclinical dose. I really don't think there's a difference between these, especially playing with the window levels, but perhaps this is a little different here. We didn't realize that, and we treated this with a subclinical dose, and unfortunately, 3 months after treatment, that's exactly where the patient failed. And this patient had several attempts at surgical and even reirradiation salvage, but ultimately succumbed to this recurrence. This patient was treated in the IGRT era, so we had a 3D image on the day of treatment, which was 14 days after the CT simulation scan. This was looked at, and the patient looked lined up. When we pulled that up to look at it, I think you can see pretty clearly, especially looking at these images, that this lymph node was growing pretty rapidly over 14 days, and that's exactly where the patient failed. So for the non-radiation oncologists, when we're looking at patients to make sure they're lined up, this shows the original CT in purple, and we overlay that with the 3D image of the day, and then we can scroll up and down, forward and backward, and left to right to make sure they're lined up in 3 dimensions. But we're not typically looking for changes and progression of disease on these images. This is another patient that we were luckier with. This patient has a right-sided tonsil cancer, a right-sided lymph node. You can see a normal-sized lymph node on the left. This patient had a surgery, a transoral tonsillectomy and left neck dissection. A week after the scan, 3 weeks later, we did this CT simulation scan. The idea was to give this side a postoperative adjuvant dose, this side a subclinical dose. I think in retrospect, this lymph node has changed a little bit, but we did not pick that up. We got in this case, a cone beam CT on day 1. You can see some of the streaking artifact that's typical. But if you look here, I think you can tell that this tumor, this lymph node is really quadrupled or more in just 2 weeks' time. So the doubling time on this tumor is a week or so. We didn't notice this on the first day of treatment, but on his first OTV after 2 days, he noticed it, and I felt it and confirmed it. We got the next day a PET CT and a FNA, and this was positive for recurrent cancer. So because he was still under treatment, we were able to give him a simultaneous integrated boost to this rapidly growing lymph node. And we gave it more than 2 gray a day, something like 2.25, in order to give the equivalent of 70 gray in the remaining 5 weeks of treatment. So this is a lymph node after 4 months. This is it after 12 months, and by 4 years, it's gone. So I think we were lucky that we found this. This probably would have shrank during treatment because it was given a subclinical dose, but I would bet you that a few months after that, he would have failed in that area. One last example, this is a patient with a left floor mouth cancer that had a resection and left neck dissection. On the CT simulation scan, we noticed this lymph node, which wasn't there or was much smaller on the preoperative imaging. So we got an FNA of that. It was positive. We treated this region then, level 1B, to 6996 at more than 2 gray a day. Treated the opposite side to 60 and 54 gray. And this patient's in ED 3 years later. So we noticed this type of tumor progression in 24 out of a group of 667 patients. So it's a small number, 4% of our patients. And I think that's right. I think we've all seen tumors with very rapid doubling times, but that's not typical. So this progression was apparent on the CT simulation scan in 22 patients. It was apparent on the cone beam CT scan in 2 patients. And about half of these we recognized in real time. And what do I mean by that? That means we identified the failure or the progression, and we modified the plan to take that into account and gave them an integrated boost to try to take care of the disease. And the other half of the patients, we didn't see those in real time. We saw them retrospectively when they failed, and we looked at their failure image and compared it with the original CT. So that's this group of patients. So the overall survival at 2 years was 83%, 10 out of 12 if we recognized the disease and modified the plan. But we only salvaged 1 patient if we didn't recognize the disease in time to change the plan. So what do we do with that information? Our current strategy is to compare or fuse all preoperative imaging with the CT simulation scan. We do actively look for changes. We treat small necrotic lymph nodes or a change in lymph node size to the equivalent of 70 gray. And I really like to get an ultrasound-guided biopsy of those lymph nodes. We don't really have the process for comparing the first cone beam CT with the CT sim and pre-op imaging. I think that would be nice to do. Moving forward, maybe we can. The first image on day 1 is an important image because if they're progressing, that's your last chance to find it. It's also your last chance to do something about it before it's too late. But to do this well, you need to get all these other images up at the same time. And at least in our clinic, this takes 20 to 30 minutes, and it's just hard to do in a busy clinic. One day we might be able to ship all these over to our diagnostic colleagues and have them figure it out, but that's not the way it works so far. In conclusion, I think this is a new pattern of failure, progression of disease prior to day 1 of radiation therapy. With the new 3D imaging and radiation therapy, that allows us to potentially identify these patients, about 4%. This type of failure was certainly under the radar in our clinic. I don't think this is necessarily a problem that just happens in St. Louis. It's probably happening in other clinics throughout the country. I think it gives us an opportunity for an incremental improvement in outcome with minimal additional toxicity. These patients were getting a subclinical dose, and to increase that a little bit to a small volume, I don't think it's not free, but I don't think it adds a lot of toxicity. And as you all know, our local regional control for some subsets of head and neck cancer is pushing 90%. So if we can move this number up to 94 to 95%, I think that would be important, especially if you're one of those 4%. Thank you for your attention.
Thank you. Stay here.